Chairman, thank you very much. First of all, I want to thank the organizers for inviting me to this extremely relevant meeting. I think we all agree that this is a very interesting and relevant activity that's happening, and that we all understand that we need to move forward in order to bring the field, the MS field, forward to a better therapeutic arena and therapeutic options. So I actually want to follow along the lines from my previous speaker and just underline that we have other measures that are relevant if we assess the ultimate goal in order preventing disability, that cognition and fatigue are major determinants of disability. So actually I'm part of a whole group of international MSologists who submitted huge numbers of comments to the EMA in the context of this call, and I just want to mention those since probably only a few of them are here. So I want to start with this slide. You have seen that also before, and I just want to stress, as you can see on the far left, that fatigue is an extremely relevant issue if you ask patients and if you assess what is out there in terms of their disability. And we all appreciate that this is one of the major reported problems from our patients with multiple sclerosis. Actually, if we look into one relevant socioeconomic aspect, it is quite striking that the probability of an MS patient to remain an active employee after onset of MS is rapidly declining. So in this analysis here, within 10 years, the likelihood that you're still working as an MS patient is only 50%. And if we just reiterate what we have been hearing before in terms of disability progression, it is quite evident that this cannot be driven just by a reduction in your ambulatory capacity. It rather reflects that cognitive decline is happening and patients may be fatigued, and therefore they are getting lost for our society as someone who can actually work in different places. The other issue that was just briefly raised is the question, how benign are our patients? We were discussing a lot about the EDSS and the pitfalls and the limitations of the EDSS. Here in this study, just recently published by Maria Amato and others, asking the questions, how benign are really benign patients, defined by a totally arbitrary definition of saying, well, someone who has the disease for more than 15 years, and by EDSS definition is in a range of 3 and below. Even in such a kind of benign cohort, half of the patients are actually reporting fatigue, and nearly half of the patients are reporting cognitive impairment. So I think we all would agree that someone with cognitive impairment or fatigue is clearly not having a benign disease, rather is confronted with something that has a dramatic impact on quality of life and the overall performance of the patient. So the question really is something here benign, or are we just missing the right measurements? And I'm not here in order to identify the right measure to say this is the measure for fatigue or the measure for cognitive impairment in MS, rather than advocating that we have to be open and we have to dig deeper to find the right measurements in future clinical trials to assess this, and to identify the need for this, and to identify drugs that can actually have dramatic impact on this over the course of the disease. So to give you some background on cognition, we heard about that before. It is an important predictor of health-related quality of life at all stages of MS. So it's not only that we do see early on, or is only limited to those patients that are far advanced in their course of the disease. It reduces physical independence. I think that's quite obvious, and this is relevant for our patients. It has a clear impact on the competence in daily activities, coping, symptom management, and I think relevant aspects. We're always talking about rehabilitation. So if a cognitive impaired patient can only partially be involved in rehabilitative measurements, therefore it is relevant to have cognition on board, and the same holds true for adherence to therapy. So it's not helpful if we have very expensive therapies and the patients are not taking the drug as prescribed, because just by their cognitive impairment, they do not understand to take the drug. So it is extremely relevant on various levels of their activities. The frequency, well, there are prevalence rates reported up to 70% of patients that apparently have cognitive impairment. And as I said before, it can be found at nearly all stages of the disease. You find already cognitive decline in patients with CIS, also in relapsing remitting MS, but also in secondary or primary chronic progressive MS. So it's independent of that. Here, one example where you appreciate that already at this very early stage of clinically isolated syndrome, so patients do not fulfill in this study the old McDonald criteria for relapsing remitting MS, and were asked to actually perform a neuropsychological test battery. There are already dramatic failures in this cognitive testing in nearly 60% of our CIS patients. This is, on the one side, surprising that at this very early stage of the disease, cognitive impairment is present. Well, in clinical reality, we are probably too lazy in order to do very thorough neuropsychological analysis. We don't do that as practical neurologists. However, if we do a very thorough analysis, we do see that. And actually, this comes aligned with the observation that at this early stage of the disease, brain atrophy is also significantly seen in patients with CIS compared to age and sex controls. So various patterns have been reported. So we know that processing speed declines over time. And as we heard before, this is not Alzheimer. We have probably to focus on the key elements of cognitive decline in MS patients. And processing speed is something that's extremely relevant. And we see that this declines more rapidly than other cognitive tasks in our MS patients. There have been various cognitive tests performed, and it turns out that speed of processing is one as the unitary or underlying deficits. Information processing speed is reduced, and the slowness is more pronounced on tasks that are explicitly timed compared with normal participants. It actually has nicely been shown that you can demonstrate this with functional MRI. So if you use simple MRIs, such a go, no-go task, and you perform fMRI analyses, you see that those patients have to recruit more areas, not only in the cerebral cortex, and this is quite visual seen here on the right side from the group from Franz Versekas from Graz, that there is a difference in patients between healthy controls versus MS patients. And you can also appreciate that this increase of additional activation is seen with an increase of the development of the disease. So on the top level, you see that patients, regardless which tasks you are giving, whether it's an easy task or a difficult task, patients with a more progressed disease in relapsing remitting MS have to recruit more patterns compared to CIS patients, and this is even more prominent in patients with secondary progressive MS. So the unmet needs are that cognition is a clear priority for patients. The assessment tools are psychometrically sound and can be used effectively, not probably by the average neurologist in daily practice. We probably need specialist neuropsychologists for that. The trouble really is that the impairment is only loosely related to disease variables, but is probably at present time more closely related to MRI measures, specifically atrophy, or in recent studies you can correlate this with fMRI. And we believe that the cognitive reserve is something that actually modulates the effect in terms of the pathology on the cognitive function. Therefore, the clinical relevance of cognition is, I think, obvious, and we clearly need endpoints that should be defined, or we should implement existing measures that potentially could be used, and this is what we also agreed upon, probably as a primary endpoint in some studies to open avenues for new medicinal products. So treating MS should not only be reduced in kind of reducing relapse activity or just looking into the disability measures on physical activities. Probably we should also be open enough to think about having therapies that address cognition in greater detail, since this is extremely relevant for our patients with MS. The other task, as seen before, is fatigue. And fatigue is extremely difficult to measure, as we heard before. It is commonly reported in various neurological diseases. If you look into the prevalence, it is one of the diseases with the highest prevalence in MS, or in general in neurology. And there are studies looking into the prevalence rate of MS fatigue. It's up to more than 80%. So there's no doubt that fatigue contributes substantially to the quality of life and disability in our patients. And if we ask patients themselves, it's considered to be one of the main causes of impaired quality of life. It is among the most common symptoms. By at least 75% of patients at some point report that they are suffering from fatigue. For many patients, it is the most debilitating symptom, even more than physical disability, and clearly it imposes significant socioeconomic consequences. We do not know, and this has also been raised before, what is really driving this, and therefore there are many hypotheses whether this is driven by hormonal changes, inflammatory changes, whether this is driven by axonal damage. We really do not understand this. Clearly, there are no major demographic differences in MS patients with fatigue. However, there's some experimental evidence that may suggest, well, probably it's driven by inflammation along the meninges, and that this drives to gray matter damage and therefore cortical loss, and this may be accounting for this phenomenon. However, we have to appreciate that the term fatigue per se is so broad that we probably should discuss the taxonomy about this. We clearly need a much better approach to identify and to dissect fatigue in our patients with MS. And as this has been suggested by Kluger and others just recently, probably we should break this up into the question whether the fatigue that we are observing in our patients is really fatigue or something that's only related to this. Is this focusing on perception, or is this really a performance fatigue? Is it clinically significant? Are there other causal factors that could drive this? And is there a particular domain of task performance affected? So you can break this up and you can see that at least in the context of MS, this is clearly a performance fatigue that we should look for, and it's driven by central factors. Whereas in other neurological domains, you can find different presentations of fatigue that may look similar, but have different causal factors. Therefore, yes, we can stratify this, and if we agree on the right definitions, then we can actually probably also agree on finding the right tools to dissect this in greater detail and to identify what we are really measuring here. So the objective tests to assess fatigue in MS and the impact of specific therapies are relevant, and this needs to be defined. Fatigue is not captured by the EDSS, as we heard before, but is a major component of disability in our patients with MS. There have been recent studies looking into 31 different assays in 38 different studies, and still there is controversial outcome in terms of what the right tool should be in order to assess fatigue. Clearly is that a self-reported outcome on the fatigue from MS patients is extremely difficult, and the likelihood that we capture depression is even greater, and therefore either we identify good objective measures, or we include the relatives of patients who may actually then contribute to the information, rather than looking into self-reported outcome measures here. Therefore, the task is that the guidelines should actually acknowledge fatigue as a relevant disabling clinical symptom, and that we should actually implement this in our future analyses and assessments. So in summary, the trouble, as we all appreciate, is that MS is very much disabling disease with a very heterogeneous clinical presentation. Our current primary endpoints are clearly driven by looking into a disability spectrum that is rather limited and is probably only partially reflecting what's really the disability that's driving our patients or worrying our patients, and therefore we should implement new measurements. We don't have those at hand that can be used as even a primary endpoint in clinical studies. And I think I would agree with the previous speakers that we should have an open book here that gives us the opportunities to be open and to be vivid, to implement new outcome measures, and to think about new studies that may address also these other relevant aspects of disability in our patients with multiple sclerosis. With this, I thank you for your attention.